So we're going to talk about alignment and motion, which is chapter 24 in our textbook, page 361. Here's some objectives that I have for us. First, we want to discuss the effects of alignment and angulation on the images that we get. We want to describe how size and shape of an object can affect the degree of image distortion. So the shape of the object itself has some impact on what we get. We'll apply Ceiszynski's law of isometry to minimize distortion. It's a pretty straightforward thing. I've got some illustrations of how that works. Actually, the people who kind of first discovered it were dental x-ray technicians, like dental hygienists were the first to use it because it helps the way that they have to position for dental x-rays. But it's been recently applied to x-ray, diagnostic x-ray. We'll talk about how SID relates to shape distortion because it is impactful. And then we'll have some rules of thumb for compensating as we angle the tube more and more. How do we compensate for that increased SID that results from increased tube angulation? And finally, we'll talk about motion. So, alignment. All right. Alignment can be defined as centering of the X-ray beam, body part, and the image receptor to each other along any form of angulation. So, in this definition of alignment, I'm including perpendicular as a form of angulation, right? But as we deviate from a perpendicular or ideal alignment, right, as we start to angle the tube or the part itself is angled or the image receptor is angled, as we start to deviate from that perpendicular alignment, we have distortion that can occur. And the two ways that those can occur that he talks about in our textbook is off-centering and off-angling. Now, those are just kind of made-up terms that he uses. A lot of times on the registry, it might just say improper alignment, improper tube alignment or something like that. But for these purposes, off-centering means incorrect centering. And so the relationship between the CR and the part in particular is off. So a good example of that would be the knee joint. We want to be as centered as possible on the actual joint. If we are off-centered from the knee joint, that joint will start to close up because of beam divergence. Okay? So off-centering, though, if it gets pronounced enough, will start to cause shape distortion, and this again is also because of beam divergence. Off-angling has the exact same effect as off-centering. So I'll say that again. They have, in terms of the picture that we're looking at, it doesn't matter if we are incorrectly angled or incorrectly centered, they have the same effect, right? And the reason for that is because the beam itself diverges from the point of the central ray. So every part of the beam other than the central ray has some form of angulation on it. So as I move away from center with the beam, I'm increasing, in essence, the angulation of the beam, right? Just because of the divergence of the beam, right? So they're essentially the same thing, right? And a good illustration of this is found on page 362 in our textbook. You can see that this angle of due to divergence on the image on the left, the angle is the same as if I had off-angled the image, right? The angulation of what was incident on the object is the same. So a rule of thumb is to keep the part parallel to the IR and the CR perpendicular to both the part and the IR. I'll say that again. This is an old rule of thumb. This one's been around for almost 100 years, I bet. I don't even know who first realized this. But keep the part parallel to the image receptor and the central ray perpendicular to both the part and the image receptor, and as centered as possible on both, right? So here's an example of a kind of diagnostic image that might be impacted, or it might actually affect diagnosis if we're not correctly centered, right? And a great example of that is the lateral elbow, right? What they're looking for in the lateral elbow, and I'll turn the lights down, is sometimes called, I think, the sail effect, where if we have a fracture of the radial head, right, we will start to see this fat pad that's come dislodged, right, and it's been slung out over the joint space. You can see it very subtly here, this little black line here. It might be better apparent on the actual X-ray images. And then we'll see a posterior displacement of the fat pad as well. That one's a little bit more apparent on this image, right? that might be obscured, right? And this is a classic sign of radial head fracture. You can't see the fracture because it's superimposed by the ulna, right? But we might do a slight oblique image if necessary. But generally, this fat pad sign is so significant for radial head fracture that they use the sign itself to just say, yeah, it's fractured, right? So if I had not centered appropriately for this image, it might obscure that diagnostic impression. Does that make sense? So this has a direct, these kinds of questions have a direct bearing on diagnosis. Can y'all think of other places where not having proper alignment would impact the kind of diagnosis that we're going to be able to make? Okay. All right, object size and shape. So not everything is within our control. Some things have to do with the way the patient themselves and the part are oriented, or the way that they look. So the thickness of a body part affects the degree of distortion caused by off-centering or off-angling. So the thicker the part, the greater the distortion, right? Also, if the part is an irregular shape for some reason, that also can influence the distortion. Also, as the part gets longer, the effects of distortion will be more pronounced. So when the body part is angled in relationship to the central ray, foreshortening occurs, right? And there's an illustration of that on page 363, figure 24.3. It shows a part that's being angled in relationship to the central ray, and it makes the part look smaller. If you're curious about ways to demonstrate that, one of the easiest things you can do is just cast your shadow on a table surface with a flashlight, right? And as you start to turn your body part, or turn your hand in relationship to the flashlight beam, you'll see your hand get smaller, right? And we call that foreshortening. When the part is perpendicular to the central ray, right, but both the part and the central ray are angled in relationship to the image receptor, we have elongation, right? And this is illustrated in our textbook on page 364, figure 24-4, right? So what I'm saying is the central ray and the part are aligned. They are perpendicular to each other, but they are at an angle to the actual image receptor, and that's going to cause the part to appear longer than it really is. Again, if you want to try this experiment at home, just get a flashlight, go into a dark room with your hand, right? And keep the flashlight perpendicular to your hand as you angle it in relationship to the floor or the wall. And you'll see your hand get elongated. The fingers will get longer, right? Now, it can be difficult to differentiate between elongation and magnification, right? But they are different. They're going to be subtly different. The telltale sign, right, as we're looking at these images here on the right, is that if we're dealing with elongation, there's going to be a portion of the part that appears larger than it should, and a portion of the part that appears shorter than it should, or smaller than it should. So of these examples here, C is an example of elongation, right? Because this part here looks fat, but this part here looks skinny, right? So I know that it's been elongated, right? All right, let's talk about Ceiszynski's law. And what's funny is you can actually Google Ceiszynski's law, and there's a law firm called Ceiszynski's law. But that's not what we're talking about here. We're talking about a relationship of triangles, which is why we have the funny word isometric. Right, that's all that means, is it's related to triangles. So we're making triangles in our mind, and we're thinking about how the triangles relate to each other. We're trying to minimize distortion by thinking about those triangles, right? Now, I'm not going to get into all the geometry here. I'm going to just keep this one short and sweet, right? And it's basically this, that if you do half the angle formed between the part and the IR, this will minimize distortion. Doesn't matter if the part's angled or the IR. So if I have a part that's angled at 20 degrees in relationship to the IR, I need to go 10 degrees with my CR and split the difference. Why? Because 10 degrees is half of 20. That's it, period. Right? Trying to keep this as simple as possible. Yes, there's more complicated ways to talk about it. It also works if my image receptor is angled, right? We do this quite a bit to correct for lordosis on portable chest x-rays. It always helps to have a slight little angle kick on there. Why? Because of Ceiszynski's law, right? Same is true with lateral knees, right? Why? Ceiszynski's law. There's not going to ever be a registry question about Ceiszynski's law. This is really just to help us be better technologists, right? This is just a good rule of thumb that gets us to be, it's that thing that separates the, what do they say, like the kids from the adults, right? Did you say what, men from the boys? The milk drinkers or the meat eaters in the Bible, right? So if the IR is angled 20 degrees, split the difference 10 degrees, period, right? That's all Ceiszynski's law is saying. Don't make it more complicated than that. And in your practice, just start noticing that. Oh, looks like there's a little angle there. I'm going to split the difference between the angle there and see what happens with my pictures. Just do it on a few patients and see what happens. You'll be pleasantly surprised that this significantly minimizes distortion. Your patients and your doctors will thank you. Okay, let's switch gears a little bit and now talk about SID and beam divergence. So I've alluded to the fact that beam divergence is a significant factor, right? I know that some of us are getting into our OR rotations, and it's very interesting to start playing with beam divergence in the OR, particularly if you're having to do any kind of rifle sighting or lining up orthopedic hardware and things like that. Guess what? SID plays a factor. Right? Centering plays a factor on all of those kinds of lineup procedures that we do in the OR. But basically, to break it down, is the degree of beam divergence increases as SID decreases. So here's a good reason another good reason to use a longer SID. It reduces the degree of beam divergence on the part, right? So that increased SID reduces the kind of degree of beam divergence that is occurring. And the best illustration I could find of this anywhere is in our textbook on page 367. On page 367, it actually shows you how the degree of beam divergence kind of marches out as we get further from the central ray at different SIDs. So a decreased SID increases the effects of distortion due to an increased degree of beam divergence, right? Off-centering causes a more severe distortion at a shorter SID. And it's saying, see figures 2411. So if we turn the page, we have this funny little coffee cup illustration here. I'm going to turn the lights down real quick. Without looking at the page too closely, look at the slide and tell me which off-centered image of the coffee cups was taken at a shorter SID. The one on the left here, right? And you can see this is the center of the coffee cup. I can see it's kind of pushing towards the middle. I noticed that push towards the middle a little bit more over here than over here. So this increased SID caused less distortion due to the decreased degree of beam divergence, right? I really like that coffee cup illustration. I think it very clearly illustrates what we're talking about in terms of beam divergence. This can be one of the more complicated things for us to imagine or think about, because we use our eyesight as a single line of sight, right? When I'm looking at something or anything, I have binocular view, so I can tell there's depth there, right? X-rays can't perceive depth. There's just one perspective that they're coming from, right? And they diverge from that one perspective. And so the ones out towards the side of that divergence are going to have more divergence than the ones towards the middle. And what we're seeing when we look at an X-ray, any X-ray image, doesn't have any perspective to it. Does not have binocular view. It has divergence, right? So it is something we kind of have to imagine how that would be impactful to the pictures. Okay, SID also has a relationship with angulation. So as central ray angulation increases, SID increases. So if I start to turn my tube, right, I'm also increasing my SID. An illustration of this is on page 369, figure 2413. So if I just look at, I had a 40-inch SID. These are both apparently are set to 40-inch SID. But if I actually measure the distance as I increase that angle, it's closer to a 50-inch SID. So as I angle my tube, I'm starting to increase the SID, right? So to compensate for this, we can measure the tube to tabletop distance. That's what TTD stands for. Measure the tube to tabletop distance, right? So, and we want to compensate for this tube to tabletop distance for central rays greater than 15 degrees as a general rule of thumb, right? As a general rule of thumb. And if you want to know why we're calling it a tube to tabletop distance, both of these, right, in terms of what the machine is measuring, it's going to tell us both of these are a 40-inch SID. But if I measure the tube to the tabletop distance, right, I need to decrease this tube to tabletop distance over here in order to affect the SID, right? So for every 5 degrees of central ray angulation, reduce the tube to tabletop distance by 1 inch. That's a great rule of thumb to use. So anytime I'm doing an angle greater than 15 degrees, I want to start to apply that rule. All right, the final thing we'll talk about is motion. Motion, either voluntary or involuntary, and we understand the distinction between voluntary and involuntary motion at this point, right? Good. It is the single greatest enemy of X-ray image sharpness. And basically there are 3 ways to decrease motion. Every registry question I've ever seen, this is a highly testable concept, every registry question I've ever seen on this has asked us to think about one of these 3 ways. And in fact, the most common one is this one right here, right? Now, it's not just going to ask you what's the most easiest way to decrease motion, right? And the answer is decrease exposure times. No, it's going to ask you something sneaky, right? For a pediatric patient with X disorder, which of the following techniques should be used, right? And we're going to choose the technique with the shortest exposure time, right? It's going to actually give us different KVPs and different MAs and different exposure times. And all I care about when I see that question is what's got the shortest exposure time, right? And still has the appropriate technique. Now the example that I provided here comes from CT because I think it speaks to all 3 of these. And it's the example of the CT head, right? CT heads, it seems like it would be a very easy exam to do. It's the first CT exam that we ever developed. The very first CT scanners only did heads, right? So you would think that we figured out how to do CT heads by now. But the difficulty with it lies mostly with the patients and the kind of people who need a CT of their head, right? A lot of them are confused. Some of them are drunk. Some of them had a stroke. They may not be able to cooperate with the examples and the illustrations and the instructions that I have for them, right? So making sure that I'm communicating with the patient appropriately for whatever their cognitive level is at is the first step to decreasing motion. If the person is combative, it may mean I need to get my dad voice on, right? If the person is afraid or confused, I may need to get down on their level and kind of coach them through it, right? If it's a kid and they don't know what the heck's going on, I may need to get out some YouTube and show them SpongeBob, right? But whatever I need to do to increase cooperation. Now, unfortunately, with the CT head, increased body part immobilization sometimes cuts right against that if you have a confused patient. Because with CT heads, I don't know if anyone's seen this, sometimes they put little wedge-shaped sponges on either side of the patient's head. If you have a patient who's drunk, some of them might like it when you do that, and some of them might hate it, right? They might try to eat that thing, right? So letting the patient know, hey, I'm going to put something beside your head. It's there to help you hold still. And if you can't hold still, I'm going to take your freaking head to the table, right? Letting them know that that's where we're at. Why? Because I'm trying to increase your cooperation, decrease the amount that you can possibly move voluntarily, right? And then finally, decreased exposure times, which a lot of times we can't do in CT, but we can control in X-ray. All right, so I feel like the CT head is an example of all three of those for me. Can y'all think of other examples of this from your own clinical site?